lady came with got it, obstructive jaundice, and we had these MRI and CT images. So I will start with the MRI axial images. So tell me if you see anything. I'm just scrolling the images. Patient has history of obstructive jaundice.
So it looks like there's some dilated biliary ducts.
Can you guys speak closer to the microphone? I heard you say dilated biliary ducts.
Yeah, it looks like some dilated biliary ducts. And then it looked like there was some yeah, so it's pretty dilated biliary duct. Looks like maybe a little small filling defect right there. And the just
Yeah.
right there.
Yeah.
Right. Concerning for like choledochal lithiasis.
Okay. So let's see. So we have in and out of phase images. So in this again, let's see. So we have this out of phase image, and then on the in phase images, we see again drop out of signal there. Let me go to out of phase in phase images.
Did we see it on coronal?
Oh, where did it? Yeah, here. So we see this signal dropout. So it could be stone, or what else it could be.
I think it's more.
And one is patient also has history of cholecystectomy in the past. One more thing.
So it could be air too, creating susceptibility.
Yeah, so the cholecystectomy was like done long time ago, like in 1991. So we have CT scan of that patient, and let's see. So on the CT scan, we see those dilated biliary ducts, and as we go distally, we see this clip here. That was showing that filling defect on the MRI. And here also on the scout, we see that clip on the scanner. So this is like migrated cholecystectomy clip, and which is causing obstruction in this patient. So
Wow.
yeah, so it's like cholecystectomy was done in 1991, and after that now patient has presented with these symptoms, and the imaging showed this migrated clip which is causing obstruction.
So did the MRI happen first, and did you guys suspect or call it on the MRI?
No, the MRI was done outside.
Okay.
And for some reason, they did a CT. On the MRI, I would have totally called it just a stone, right?
Yeah. That's why the CT is so much more helpful.
I know. And then the in-phase helped a little, but then we've seen some stones even show a little loss of signal on the in-phase. So, and then when you look at the scout, it's like, what's this odd clip doing here? And anyway, these migrated clips are a nidus for stone formation. Apparently, this is a known complication in 10% of cholecystectomies. And the median age, they said, was anywhere from 9 to 20 years. And ours is like 20 plus years since the cholecystectomy. So one thing they said was you can get necrosis of that cystic duct stump. So that's why it's the path of least resistance, and the clips will fall into the CBD. What causes necrosis of the cystic duct stump, we don't know. If it's a vasculopathic patient, it could just be ischemia to the cystic duct, or there's some reports which said if there's excessive motion of the abdominal wall in a certain direction, that can predispose to cystic duct stump necrosis, and then clips just migrate. So just a cool scout case and a pitfall on MR.
Very cool. I'm shocked that you said 10%, but you're saying 10% will migrate, not necessarily down the CBD, but like,
10% will migrate. Yeah,
okay.
Exactly.
Very cool.
Okay, I will.
There was a ovarian mass seen on ultrasound, and we got an MR. I think this is a good resident case. Maybe a senior resident, if we have any.
I'll take it. Residents, do you guys want to speak up? I see like a really T2 dark structure in the ovary. And is the cystic part of it? Is it like is it a multi-component thing or just mainly that? Okay, it's a multi-component thing, right?
I think the cystic, I think it's ovarian, and maybe these are like giant follicles, ovarian cysts. And then there's also that T2 hypointense mass, like you said.
Okay, so when I think about
And it's
solid
lobulated, yeah.
masses that are
Good.
really dark, T2 dark, I think about like fibroma. It's going to be an ORADS 2. They're not as concerning as like the cystic ovarian neoplasms if they're solid, and especially if they're really T2 dark like that.
Good, yeah. And here's the enhancement subtraction. It's enhancing, homogeneously enhancing. And the T1 is right here. All right, just had it. And it's kind of iso. Good. So this was a case of ovarian fibroma, and I wanted to do a review. If I can drag this. Can you see my screen? Yes, hopefully you can. Okay. Good. This was a paper written by Atul. He's in Boston, one of the abdominal radiologists. And he looked at features of fibromas and fibrothecomas. It was published in AJR. So they, fibromas, they are, I don't know that we can tell the difference on MR, but pathologically there is a difference between fibromas and fibrothecomas. And it has to, like it says here, for example, fibromas have these whorled fascicles of, I mean, these are just, for me, words, I don't know what they look like, but fibrothecomas differ because they have sheets and nest of plump spindle cells. They are associated with MEG syndrome. So they can present with pleural effusion or ascites, and it's associated with a syndrome associated with basal cell nevus, Gorning-Goltz syndrome. And so in that syndrome, patients get multinodular bilateral ovarian fibromas. They get skin findings too, basal cell carcinomas, and other physical findings. On imaging, they are T2 hypointense. So the study looked at patients with fibromas and fibrothecomas, and I think like our case, they on T2 are dark, hypodense. So that most commonly, but they can also be hyperintense, a little bit brighter on T2, and they can have capsules. Big ones tend to be associated with capsules more often than smaller lesions, and some can have cystic changes. So there are really great examples here. So here's some kind of more like a capsule here that surrounds this larger fibroma, and T2 kind of heterogeneous, especially along the periphery. Here's like a few more examples of T2 hypointense. The reason this is important to suggest or kind of diagnose is because fibromas are benign. So they, there's no risk of malignancy. So when they looked at, oh, and here's, where you have cystic changes. So they can have kind of degenerative cystic changes, essentially, like you see here. And then a few more subcapsular, the cystic hyperintense T2 signal. So they can have this, and then those are seen especially with the larger ones. So this was just a really nice classic case of fibroma, surgically proven.
Nelly, I have a question.
Yeah.
Would you put Brenner tumors in the differential, and are there any imaging features that help us pick these? Because I've always thought they're all in the same, like ovarian tumors containing fibrous tissue spectrum.
That's a really good question. Aarti, what do you think? I don't know. I don't think about Brenner tumor when I see these kinds of lesions.
I think
Aarti.
that Brenner tumors are solid epithelial neoplasm. So in general, when you have a solid mass, they're in the differential for an ovarian solid mass. However, they're pretty rare. They're, I think, low grade, and I think they're not as dark as fibromas. So they tend to be more intermediate signal. But either way, I remember asking this question at a conference where people were talking about ORADs because these dark solid ovarian masses end up in the ORADs 2 category. And I remember asking like, well, how do we exclude a Brenner tumor? And I think somebody told me that, they wouldn't be as T2 dark, and they're also pretty rare and are pretty low grade. They're not the type of ovarian malignancies that actually, are the really aggressive ones. So that's my impression at this point.
While Aarti was talking, go ahead.
No, go ahead, finish.
No, while Aarti was talking, I Googled it. I was trying to, so, sorry, I don't want to reference Radiopedia because I know we have some of our viewers who are pro peer review papers, but yes, like Aarti already mentioned, they have T2, it's hard to differentiate, but I guess it turns out Brenner tumors often have calcifications in majority of the cases. So I don't know that helps, but I don't think calcification was a feature of fibrothecoma spectrum lesions.
And actually, can you scroll up? Does it say
Yeah.
if they're always benign or uncommon epithelial?
Aarti, see, it says where it says it can be associated with malignancy in the ipsilateral or contralateral ovary. And that's why I was confused, like, would we put this in an ORADs too? Because does that mean by itself it's benign? The tumor it can be associated with is malignant?
Well, I think if you see something concerning in the other ovary, you have to be concerned, period.
Right.
But the Brenner tumor itself, I think, is not that concerning. But I did bring up this exact question. Now I'm Googling about like ORADs, because I know that one of the things is like if it's dark, that's ORADs 2 for all of these kind of fibrous lesions. But I will try to look that up later.
But I guess your point makes sense, is that if it's more intermediate and much more solid looking, don't put it in the benign fibroma, fibrothecoma spectrum, right?
Exactly.
Okay.
Yeah.
Thanks.
And this paper that I found, I mean, they have some images of examples of let's see. So fibrous. So these are Brenner tumor. These things. So here, I guess solid cystic diffusion. I don't know that the diffusion is helpful for me here. More examples of Brenner, and they do look like fibromas, right? Like, look at that. I mean, I could call this fibroma. And then here it has calcifications on CT. I don't know if fibromas have calcifications. I think generally, I think they don't. And then calcifications, and then you have, yeah. So I don't know. I think it would be hard to separate them, definitively.
Well, in that article, it said BBT. What is BBT? But is it benign Brenner tumor or just Brenner tumor?
Yeah.
Yeah.
Yes.
Okay, so yeah, benign Brenner tumor is by far the most common, borderline, and then I think the malignant variant is pretty rare, but probably should have more aggressive looking features. Okay, cool. There is also one other thing, Nelly, that your case was reminding me of. There's something called a cyst adenofibroma, where you have really T2 dark, like fibrous components, but also cystic components. And that can be like a mimicker of malignancy, but the clue is that you have those like really T2 dark components as well. So, but that's usually like a retrospective diagnosis. Okay, Akshaya, do you want to go?
So,
Sure.
Sorry, this is the ovarian cyst adenofibroma that Aarti just mentioned. And here are some examples of what they look like from Radiopedia. It's a lot more cystic looking.
Yeah, exactly. And then it might have like a couple of smaller T2 dark areas, but it is still a benign thing, but usually it gets resected because it, you're going to be worried about a cystic epithelial neoplasm.
Okay, sorry. In this case, I'm not sure where it is, but
I think that other bigger one was a more dramatic example.
Okay, so this she's 29-year-old female and has history of like recurrent pancreatitis. So I'm just scrolling through the images. Anyone can take the case. Just tell me if you see any abnormality anywhere. Mainly focus on the biliary and pancreatic ducts. So I'm going down slowly.
can you double click on the
Hmm.
axial to make it
Thanks.
bigger?
Okay. Oh, you
Oh,
you
okay,
want
maybe it's not. Never mind.
this is I means I set up the slides like this,
Oh,
so I
that's
have
fine. Yeah.
some more MRCP images afterwards. So
You see a little bulge of the CBD at the ampulla.
mm, you mean here?
Down
Okay,
down at the ampulla.
down here.
Right there, like it's a little bit bulgy, but I wouldn't necessarily call it like a type 3 choledochal.
Okay, so let's look at the MRCP images now here, and I have some more which I can scroll.
Are they? I mean, is it a common
Hmm.
Oh
insertion?
yeah, that's an ABPJ.
Yeah, so this is a anomalous what ABPJ, biliary-pancreatic junction. So like the CBD, like if I show you here, the CBD is inserting into the pancreatic duct and they have that common channel and which is dilated here.
And
So
like, what's the distance again that you need? Is it 1 centimeter or 1.5 centimeters?
1 centimeter, I think, one
Okay.
centimeter. Yeah. So this was so this patient had ERCP done and they like diagnosed it that patient has common channel and the CBD is inserting into the pancreatic duct and CBD had like some like kind of sludge there, so they removed that sludge and they put the stent like before this scan. During the scan they removed it, so that is the diagnosis. So just wanted to share one article related to that. I think I have to pull it here. Do you all see my article?
Yes.
Yes. Can you zoom in?
Mm, you want me to? Yes, plus, okay. Okay.
Perfect. Yeah.
Is on like as they are describing the in patients with this ABPJ, the sphincter of Oddi does not regulate the pancreatobiliary junction, and a reciprocal reflux of pancreatic juice and bile can occur. And this reflux pancreatic juice injures the biliary epithelium and promotes the cancer development. And this is the way like the my case was showing similar thing that the CBD is inserting into the pancreatic duct and they are like entering into the sphincter of Oddi as a common channel. And also they now it has different types as they have described, I think on the next page. Yeah, here. So it could be stenotic, non-stenotic, dilated channel or complex type. So here like CBD is stenotic and it is joining the common channel. Here it is having normal caliber and just joining the normal channel without any obstruction or anything. And this is the case which I showed where the CBD is joining the common channel and the common channel is dilated. And this is the case where we have pancreatic divisum and little bit complex anatomy. Also they said like these patients are like prone to then recurrent pancreatitis, also biliary stones. And we also see either dilated biliary ducts. No, like with the common channel we can see dilated ducts. The ducts will not be dilated and this is just the normal anatomy. Like the normal MRCP, we will see these structures like CBD, then cystic duct entering here, and the pancreatic duct, it is joining here at the sphincter of Oddi. In the case which I showed, it was showing somewhat similar appearance here. Like CBD is entering here, and this is the dilated common channel. And in some cases, we also see dilated extra and intra, like here, extrahepatic biliary ducts, like how we are seeing here in this case. And one more point
In
for
that in the dilated duct case, you would bring up a choledochal cyst, right?
yeah, we can bring up the choledochal. And one more point I wanted to discuss is the management for these cases. So in my So let me tell you the in general management, and then I will talk about the my case, which I showed. So here they are saying the because of it is the risk for biliary cancer, uh, we have to manage the patients based on whether they have biliary dilatation or they don't have biliary dilatation. So if the patient has biliary dilatation, most of the them biliary cancers, they are located in the gallbladder or dilated common bile duct. So these patients, they prefer to go for hepaticojejunostomy with Roux-en-Y anastomosis. And if the patient does not have biliary dilatation, then they are planning to do prophylactic cholecystectomy, because most of the biliary cancers develop in the gallbladder. So in the case which I showed, patient did not have biliary dilatation. So they are planning to do prophylactic cholecystectomy in that patient. And also considering patient's age, she's just 29-year-old, but she has like family history of biliary duct malignancy.
And did you say your patient was having pancreatitis, like recurrent pancreatitis?
Recurrent pancreatitis.
Okay.
And one more point I wanted to share.
But the cholecystectomy is not going to necessarily solve that recurrent pancreatitis problem.
It's for the
It's
malignancy risk.
just to reduce the her risk of malignancy in future.
Okay.
That
And
is
I
it.
think, like, do they also, or I had a case of anomalous pancreatic biliary junction, and learned from our interventional gastroenterologist that, patients have to get surveillance ERCPs.
Yeah.
Yes.
Yeah, so she also has to go for that also ERCP. So they are planning for this cholecystectomy, and she has to do follow-up scans.
Yeah, so if we're going to raise that, just know that it has major implications.
Yeah.
Because this patient was symptomatic, but sometimes it's just incidental finding. And
Mhm.
so you're, chasing an incidental finding and causing a lot of like complex issues downstream for the patient and the health system.
Yeah, but like she's symptomatic, like with recurrent pancreatitis, etc. So I think like if the patient is having symptoms, then we have to like address that, and I think we have to do some prophylactic, either cholecystectomy, etc. If it is just incidental and patient doesn't have any like complications or anything related to that, then I think we can just pass it. Is that correct?
I don't think we could just pass it, right?
Then
I mean,
if it is
if
like incidental, oh, then you mean like we have to do like surveillance, ERCP, etc.
right. So
I mean, I
if
think they have to then be seen by a gastroenterologist and then
Okay, got it.
assess their risk factors and stuff. But in the opposite realm, I've had cases where we see a really dilated common bile duct, and then my surgeons or gastroenterologists ask me to look for an ABPJ, like to support, like to see if that would support that there truly is a choledochal cyst. So I do think it's important, even if you don't see it immediately. Like if you see a dilated duct, that's a secondary finding that you should look for.
Mhm. Okay. Also, I think I wanted to bring up some more slides here. So like these are other things we see with the dilated ducts, like Santorinocele, where we have just like it is most commonly seen with the pancreatic divisum, where we have the ventral dorsal pancreatic duct ending like entering separately into the duodenum through minor papilla, and it has bulbous dilatation at the end. Another thing I was reading about it, and I read about this Virsongocele, where the main pancreatic duct just show bulbous dilatation at the end, but the CBD is ending separately here. So it's not like a common channel. And choledococele, which is bulbous dilatation of the CBD. So which is one of the like type 3 Todani classification. It will come as. So these are some other things which we should keep in mind while looking for this ABPJ and some other like dilated common channel, and other differentials would be this for in this location. So just wanted to share this. That's all. I think I will stop sharing.
and those don't have malignancy risk, do they?
Yeah, correct. Those don't have malignancy risk, but just wanted to show the difference between Virsongocele and the ABPJ. Like the Virsongocele will have like normal pancreatic duct with just bulbous dilatation, and CBD will have a separate opening into the duodenum. But in ABPJ, the CBD will end into the main pancreatic duct, and they will have common dilated channel.
Yeah, Nelly, these I don't think those have increased malignancy, but they do have,
No.
they're associated with pancreatitis because one of the causes of the Santorini seal or the Friszinga seal is a small opening, and so it's getting like obstructed at that level.
Yeah, so I think they said it could be just incidental finding and patient can present with recurrent abdominal pain or recurrent pancreatitis in Wirsonga-seal. So it is not like any congenital anomaly. Wirsonga-seal.
Okay.
This patient had flank pain and got a CTU.
So we see a bladder stone just beyond the UVJ. Oh, is it in a ureterocele?
Nelly, you're mute.
No, I'm not talking. Just-
I think
so
Aarti said ureterocele, right?
ureterocele, good. Okay, what's another consideration? What if I said patient had a history of reflux as a child?
Like silicone injection at the UVJ?
Yeah, so it's a
Botox
deflux.
injection?
This is deflux, yeah. So this is an example of deflux. Here's a paper from AJR and looking at different kind of implants that we can do for reflux, treatment of reflux. And this is what it is. It's a dextromer hyaluronic acid. It's here. This is what it looks like. It's low density on when they do a radiograph. And then when they inject it on ultrasound, it can be bilateral depending on side of patient's reflux, and it has a very homogeneous echogenic appearance on ultrasound. On CT it looks like what we saw on this study. So you have this hyperdensity at the ureterovascular junction, and the idea is they're trying to inject it to kind of elongate that trigone, or try to kind of reduce the risk of reflux. So this is classically, and it's a submucosal injection that they do, and here's additional examples of that. Yeah, so it's
If you scroll up 2 pages, like why is it sometimes dense, and like there's also an image E there where it's not dense?
That's a good question. Let's find out what E said. Had dextromer, no, like to me this is like ureteral seals, bilateral implants with mean attenuation. Oh, I think that maybe it's the material. So I think maybe over time it has more density, but at like after on radiograph it has this low density, so it's not super dense like calcium dense. And what I suspect is probably like immediately after injection it's low density, and maybe over time it becomes, the body just tries to do its thing, and then it like becomes more dense over time.
It says the low density one is 1 year later, and then the high density one is 3 years later in the captions there.
Gotcha. Okay.
So it seems like it gets denser over time.
Yes, I think that that's probably what it does. And so this patient was in her 20s, and so the procedure was done when she was much younger.
Very cool. Pitfall for a stone. So I want you guys to focus on the liver and the vessels of the liver and tell me what's unusual. Residents? Anyone?
Those hepatic veins going to the right spot? Can we scroll a little higher?
The hepatic veins are going to the right spot. They're going to the IVC here. But there is something weird about the portal vein.
It's like an anomalous.
Yeah, it's going directly into the IVC. If you notice, so that splenic vein and the SMV actually do come together and they form a portal vein. And then instead of going into the liver, that portal vein
Abernethy
then goes
malformation.
directly into the IVC. So this is a congenital abnormality. Does anyone know the name of this?
Abernethy malformation?
Yes, excellent. So I'm going to show you a picture. Here are the different types of Abernethy malformations. So either your splenic vein and your SMV can separately drain directly into the IVC, or they can form a common trunk. That's the type 1B that I have in my case, directly draining into the IVC. Or you can have a type 2 where you have kind of a hypoplastic portal vein and a connection to the IVC. So you still have somewhat of a portal vein, but most of it's draining into the IVC. All of these are called Abernethy malformation. They're congenital portal venous atresia. And one of the consequences is that it can cause hepatic encephalopathy, because as you can imagine, all of the GI blood flow is actually going straight into your IVC, so it's not getting detoxified by your liver. It can lead to high ammonia levels, but also it can be asymptomatic. And in my particular patient, this patient was basically asymptomatic. This was incidental, but they started having findings in their liver on a random scan. And so these patients, because they have vascular abnormalities, they're more prone to getting both FNH as well as HCCs. So you do need to screen them. And then also you need to look for, hepatic encephalopathy as well. Any questions? Okay.
This is a patient, history of presumed HCC, pre-transplant evaluation, had a prior ablation, and patient is getting just surveillance screening. So this is just, so that's the ablated cavity at the site of prior hepatic lesion. Here's the post-con. I'll give you T2 axials.
Something going on with their colon?
Yeah. What do you, here, let me go back to the coronal.
Like a spiculated edge. With like, oh,
Nelly?
there's like fecal gray.
Yeah.
Oh, Gitanjali said cecal malignancy. There are nodes and.
Good. Yes. So this was here it is right there. It's maybe at the hepatic flexure right colon. There's a mass right there with T2 intermediate signal. Like Aarti said, it's kind of irregular. You lose the normal serosa, and then lymph nodes. There's lymph nodes right here. So this was an incidental pickup on MR, and it turned out to be indeed colon cancer. And so the teaching point is, to just, I think we had a case, or I don't know, I think was it last week or the week before, just trace the colon, because colon cancer is not infrequent, and we see them incidentally. And so, even if you're getting an abdomen, trace the colon, and these can help and improve patients' lives. And yeah, so it was a really great pickup.
Yeah, that might even be like more impactful than, a small HCC or something.
Yep, exactly.
Okay. So this is kind of a companion to what we were talking about earlier today. This was a multi-cystic adnexal mass. You can see that there's multiple cystic locules, a little bit more complex area centrally here. I'm going to show you the post-contrast. So there are enhancing septations, but then also maybe a little bit more solid enhancing component here. There was nothing that was T2 dark, so this is not a companion to like the cyst adenofibroma that we were talking about, but basically this is a multicystic mass with enhancing septations and maybe a solid part here. So it's going to be a surgical lesion. It didn't have any fat in it in and out of phase. It didn't have any bulk fat. And anyway, there's no way we could have told what this was prospectively, but the final path, I'll show you the high res too. Here it is. Complex, it's got different components to it. Anyway, the final path was struma ovarii. So something I hadn't actually seen in my practice, but vaguely remembered from board studying. So struma ovarii is actually a type of dermoid. It's a type of teratoma where at least 50% of it is made out of thyroid tissue. Patients can get thyroid toxicosis. So if they have like a thyroid storm or hyperthyroidism and you have an ovarian mass, that's something to think about. It overlaps with other epithelial neoplasms. So it's basically a retrospective diagnosis unless their thyroid hormones are elevated. It can have multiple different cystic components with different shades of gray, sometimes with some really T2 dark areas, but basically it's a surgical lesion. And I think that was all I was going to say about that. Let me just check my notes.
Are there no clinical symptoms in her for thyroid related?
No, this patient did not have clinical symptoms, and they hadn't checked her thyroid function. It was interesting. They did like a whole ovarian malignancy panel in the labs, like CA125, CA19-9, AFP, BCG, all these other things, but they did not check a thyroid level. But I think it's just because it's so rare. And then 5 to 8% of these patients that have struma ovarii can have thyroid toxicosis. So even if they have struma ovarii, it's still kind of rare to have thyroid, over function. Nice. But I didn't also quite realize that it is a type of teratoma. It's a monodermal teratoma, predominantly composed of thyroid tissue. The other one interesting thing that I thought of is like, looking at it in retrospect, like, could we have suggested it could be thyroid tissue? And, thyroid tissue is generally solid and avidly enhancing on CT and MR, and these struma ovarii are generally multi-cystic. So it doesn't even really look like thyroid tissue.
This patient is a week post-op from cholecystectomy and came in with right upper quadrant abdominal pain. Easy ED visit. Just
The clips do not look like they've migrated into the CBD.
good.
And they look like they're in appropriate position.
Perfect.
I don't see a biloma or fluid collection, and I don't really see much of Bildel.
Good.
Nelly, is the portal vein just volume averaging? Will you window?
Oh, yes. Portal vein is patent.
Okay.
And it is volume averaging. We have a subsequent CT that shows that.
Is there bowel that's abnormally enhancing in the left lower quadrant?
Yeah, what do you think about that?
Is that sigmoid colon? Axials? It's like a long segment of wall thickening.
But it looks kind of apple core-ish. I feel like you have to bring up malignancy again.
Yeah.
There's a little mesenteric congestion too, but if it's an older patient, definitely scope to rule out a malignancy.
Yeah, this was another case of incidental colon cancer. So a companion case, just again to, just trace the colon from the beginning to the end, because colon cancer is common, and we see them not infrequently and diagnosed incidentally.
Very good reminder to trace the whole colon.
Okay. History withheld.
Abnormal urethra.
Yes.
Oh, like with tumor.
Good. Yes. So this is, we don't, I feel like we don't often see, so it's this, but it's a great example of it. This is a patient who, it's a woman, and you can see this T2 kind of evil gray T2 intermediate signal in the urethral mass, and there's local, it's, locally invasive. Here you can see this is a urethral wall, and then you can see the tumor extending beyond the wall into the adjacent muscle,
Actually, Nelly,
retropancreatic fat,
stop.
maybe.
Yes, stop down one. It's a good example of like the targetoid normal appearance on the patient's left side, and then the sort of loss of the normal targetoid anatomy on the right side.
Yep. The internal external sphincter, that is what creates that targetoid appearance. And this was a proven urethral cancer.
And no nodes or anything.
No nodes. Yeah, it was, but it was locally invasive, and so like it went like there was like it developed a fistula to the adjacent kind of periurethral space and muscle.
So in general, female urethral tumors, more proximally, the closer they are to the bladder, they'll be urothelial, and the closer they are to the skin, they'll be squamous cell because they're contiguous with the skin. And if they're locally invasive like this, they might need like a pelvic exenteration.
This one was a clear cell variant of urethral cancer.
Oh,
They're
interesting.
normally like transitional cell, but this one was a clear cell variant.
Cool. Okay, I think we're gonna stop for today. Thank you.
Thanks all.
Thank you.